Growing Pains, Mental Health and Mississippi's Children.
I'm playing with my son's medicines. I know I shouldn't be doing it, but I'm desperate.
When we're not certain if medication is going to really help, and if medication will help, of all of the different drugs available, which one will be the right one?
And I really was worried about having my child on medication. So all the time he's been on his meds, I've constantly asked him, how do you feel?
And now, Dr. Rick DeShazo and Melissa Faith Payne.
Having a child with mental illness can be a demanding undertaking for families and can be a strenuous trial for physicians.
On this program, we'll talk to families and doctors, and our panel of mental health professionals will talk about how to find help.
We'll also talk about the risks and rewards of psychiatric medications, but first, how do you treat mental illness in children?
It's not a cookbook, cookie cutter, one-size-fits-all type thing. You want to tailor your treatment to the individual sitting across from you, because he or she's a unique person, and you need to do good work to find out exactly what's going on with that individual and then fit the best treatment possible to him or her.
Dr. David Elkin is a psychologist at the University of Mississippi Medical Center. He says the typical treatment with the best results for children with mental illness is a two-sided approach: behavioral therapy and medication.
For instance, treating children with ADHD, attention deficit problems, the standard go-to goal treatment is a combination of cognitive behavioral therapy and medication. And the results you get by putting them both together are much better than treating with either one alone.
Dr. Elkin says some mental challenges can be fixed, while others must be managed to help the patient cope. He says doctors should work with families within expectations and be clear on what can and cannot be done to help the child.
I wish there was a blood marker for it. You could draw blood and see if someone's depressed. I wish that it was visible on an MRI. There's the tumor, cut it out and it's gone. It's not like that because you're dealing with the brain, and it's a much more complex organ. And so what we try to do with a lot of folks is give them the tools within expectations that they can live a healthy, productive life.
Dr. Elkin says if the mental illness is rare, it is more difficult to treat, especially in young people.
I was talking about it to everybody that would listen. And one day, he had been gone for a few years, and we had been on all these, he had been in a day program, he had been in hospital a number of times, and I'd asked everybody if they knew who could help me, and I just happened to be talking to one of the psychiatrists at work. I called her and I said, I know I'm playing with my son's medicines. I know I shouldn't be doing it, but I'm desperate. Because, Ryan was just sitting in one place. Oh. And she didn't fuss at me.
Pat Montgomery, whose son Ryan was diagnosed with schizophrenia, says it took a few years to get the right help, going from doctor to doctor, from medication to medication. Eventually, electroconvulsive therapy made a difference.
Initially, he was in the hospital for his first few treatments, and you could tell how tortured he was just by looking at him. It was really scary not being able to help him. But after his first set of ECT treatments, he had his 7-year-old smile was back, and we hadn't seen him smile in a very long time. And he didn't remember any of the horror that he had been through for all those years.
Historically, many cultures viewed mental illness as a religious or personal problem. This viewpoint continues to impact treatment for mental illness. According to Lifeway research, 48% of those identifying as born-again, evangelical, or fundamentalist Christians believed with Bible study and prayer alone, people with serious mental illness could overcome it, while only 35% of all Americans agreed with the same statement.
In the charismatic church, we do believe in the laying on of hands and the anointing with oil.
Sharon Townsend says their faith practice has been a part of the treatment for her son Damien, who was diagnosed with ADHD and bipolar disorder.
I keep olive oil, which we call blessed oil, here in the house and use it on a regular basis. And what we have come up with after years of fasting, years of praying, is that Damien himself is going to have to want to take control of that negative energy and not let it overpower him.
How do you access treatment for a child? Joining Dr. Rick DeShazo are mental health providers Dr. Timothy Summers, Dr. Susan Buttress, and Dr. David Elkin.
What are your recommendations to those folks who are watching about how is the best case scenario to get someone that you think needs some help?
The best case scenario is to go to your pediatrician or your primary care provider first and say, I need help, and let them know what the issues are. Accessing directly a mental health facility is, one, not easy, and often it's important to first get that medical checkup and just make sure everything else is okay, like sleep, like diet, like there's not any other health issue.
What about physicians who say, I don't make referrals? We're hearing that is said.
Some.
Yeah.
Yeah, that's just not appropriate. If there is a physician who believes that there is a problem yet won't move forward with something, then I would suggest that the parent find another provider. Honestly, to refuse to try to help that family access help is not appropriate.
So how does a clinical psychologist decide that talk therapy is not enough and you need some help on the drug side?
You know, someone like myself does talk therapy. I cannot write prescriptions. So I have to work with colleagues who can, because the research shows that for most children, the combination is the best.
These drugs are scary.
Yeah.
I mean, you got some high-powered stuff you're working with, and including these antipsychotic medicines that they're using them for everything. What's going on with all these chemicals?
We treat children who have problems, and the basic underlying problem is a biochemical problem. The brain is producing too much of a certain chemical, too little of a certain chemical, and so we use drugs to kind of bring those chemicals back to a normal level so that you don't have mood disturbances, activity disturbances, attention concentration disturbances, etc. So we use that, but unfortunately, we don't, when we start treating someone with medication, we never know what medication is appropriate. Number one, we're not certain if medication is going to really help, and if medication will help. Of all of the different drugs available, which one will be the right one, and of those drugs, which dosage is going to be the right dosage. So it's kind of like an art and a science, and kind of almost like a trial and error thing. And unfortunately, most of the medications that we use now do have potential adverse effects, like causing diabetes, hypertension, enlargement of breast, gynecomastia, mood disorders, those kind of things. But generally, we look at the risk versus the benefit, and if we think the benefit outweighs the risk, then we'll select the medication and give that a trial. Many parents don't want their children on medications. And then, too, a lot of physicians on the outpatient setting who are treating children in a clinic, they are not comfortable using high doses of medication. Then frequently, as I stated earlier, one medication may not be enough. If you have a child who has bipolar illness and ADHD and anxiety and other problems, you may have to use 2 to 3 medications. The parents don't like it, the children don't like it.
And the primary care people like me are neurotic about it. I get these kids into practice and young adults on 4 different medicines.
That's right.
And I didn't get enough training to understand the pharmacology about how all these things interact. They come in for a different problem, and I will usually attribute it to those medicines, and then I get in a fight with the psychiatrist.
That's fine. And frequently it is because of the medications. I keep adolescents in the hospital for 3 to 6 months. Well, it might take me 4 months to come up with the right combination of medications. And I discharge a patient home. They start seeing someone as an outpatient. The outpatient doctor changes all the medicine, and the next month they're back in the hospital again. The parents don't like it. And then, too, parents in general don't like to think of their children as being mentally ill to the point that they have to have medication. So there's a lot of stigmata associated with having mental illness, having to take medications. And so compliance with medication is very poor. You can get children on medication, they function very well, and then in a month or so, about 80% of children who are started on medication in a month, they stop taking the medication. So you have a lot of recidivism or reoccurrence.
Entrance into behavioral health care, mental health care is confusing, disjointed, and disconnected. And that's not just in Mississippi, that's nationwide.
The children typically aren't going to ask for help, so it has to be the parent who is able to step through and be able to realize that the best thing they can do for their child is to ask for help.
Debbie Waller started with her son's pediatrician. Michael was first treated for ADHD in grade school, but his condition changed as a young adult.
He said, I don't know how to tell you this, but I think it's a mental health issue. He's delusional. He's hearing voices. We did all the blood tests to make sure he didn't have any contagious diseases or anything like that, and he doesn't. But I said he needs to go to a psychiatrist. So we took him to a psychiatrist, and our first diagnosis was schizophrenia. And they put him on medication.
Advocates say some mental health care providers, including psychiatrists, psychologists, and therapists in Mississippi, accept insurance assignment or Medicaid.
So we see people on a sliding fee scale, regardless of their ability to pay.
In Mississippi, there are 15 regional community mental health centers that contract with the State Department of Mental Health to provide community-based services.
And the good thing about our community mental health centers is that whether that person is indigent, has Medicaid, and many of them do, or have private insurance, the community mental health center will not turn them away.
And for families in a mental health crisis, taking the child to a hospital emergency room can be a last resort.
Usually individuals who go to the ER are an imminent threat to harm themselves or others.
When this occurs, a doctor at the hospital will determine if the child needs to be hospitalized. Depending on the age, the child could be admitted to the hospital or to an acute care psychiatric hospital.
The emergency department is one entrance there. The problem is, where do you go after that? A lot of these kids will then go to an inpatient unit because they are deemed to be a threat to themselves.
In Mississippi, there are 7 acute care psychiatric hospitalization programs for children that provide short-term treatment. Each accept Medicaid and private insurance, but it is up to the insurance companies to determine the benefits paid.
Acute care typically is 2 to 3 weeks, depending on what the insurance will agree to. So the insurance companies actually decide what the children need, not the physicians, not the therapists, not the parents, but the insurance companies.
Sharon's son Damien was diagnosed with ADHD and bipolar disorder and entered the system through a community mental health center at age 5. Damien's mental health problems have been treated in acute and residential care settings and at the state hospital.
After 2 years at home with Damien, his behavior started to escalate. He was taking stimulant medications. His moods were getting worse. I thought that keeping him at home, staying at home with him, was in his best interest because I did not want to send my baby away.
Sharon said her son wasn't sleeping, was angry, and was exhibiting antisocial behavior.
Oak Circle is the state hospital for children, the state mental hospital for children. Damien went to Oak Circle on November 15th of 2013. He stayed there 3 months, and he went to Mill Creek about February, and he came home November 18th of 2014, so about 9 months.
A child's entry to Oak Circle at the state hospital is through a Chancery Court commitment process. Even though Sharon retained custody, the state hospital personnel made the decision of when to release him.
That was the hardest thing that I've ever had to do in my life, was to sign those papers, because he has been, and he is, my world.
Lack of access to mental health care, what are the answers? More with Dr. Rick.
In Mississippi, we have real access issues. What are the opportunities? I know that there's mental health districts in the state, and then there are private practice, and there's, what are the options for someone?
The answer is not necessarily to hire 30 more psychiatrists and 30 more psychologists and place them around the state. It won't work. You've got to work with available resources that are there and train individuals on how to care for the kids where they live.
Well, what you're doing, it sounds very encouraging, but it ain't done yet.
It's not done.
So in the short term, how do parents navigate and patients navigate through this morass of options? The fact that we don't talk to each other as much as we should. We're drowning in these patients, large numbers of them. It's a very, very messy situation. So can you give us some pointers about how to navigate the system?
Probably.
With and without money?
With and without money. Now, that's one issue to us in the K Center, is to treat everybody the same. It is not appropriate when, 60% of our children are on Medicaid, to have the Medicaid population go somewhere else. They all should get treated equally, and all should have the same care.
Or have a different set of drugs they can get.
Or have a different set of drugs.
And then that...
Exactly. Everybody should have access to the same care. That's the way we'll have everybody having a good outcome. So again, our advice is that go to the primary care provider, let them know what type of problems are going on, make sure that they have a good physical and neurologic exam, and then to determine where they need to go next. We have set up a triage system so that if they come into the University K Center, then they see a physician and a psychologist and get an intensive history. They may not get a diagnosis. What they may get is a list of symptoms and some things that need to happen next.
Xanax, Depakote, Adderall, Concerta, Zoloft, Thorazine. These are just some of the psychotropic medications used to treat mental illness in children, such as depression, anxiety, attention deficit hyperactivity disorder, bipolar disorder, and psychosis. Sometimes the first drug prescribed doesn't work well, and families must try others to see which one will improve the child's condition.
There's no specific treatment that we can say, this is you've got schizophrenia, this is the thing that's gonna fix it. We don't have that like we have for diabetes, for other organ illnesses. It's trial and error. And you have to stay on a medicine for so long before you even get a glimpse of whether it's going to help.
Dr. John Pruitt, a psychiatrist at the University of Mississippi Medical Center, says newer versions of antipsychotic medications have a better side effect profile, but there are risks.
These drugs do cause weight gain, and they can lead to pre-diabetic states, increased blood sugar, insulin resistance. You can also have lipid abnormalities where your blood fats go up, which can lead to heart disease later on. All the problems associated with obesity. You still can get movement disorders. So we don't use them lightly. It's got to be fairly serious before we'd go to an antipsychotic. And unfortunately, antidepressants don't work in the younger kids. They may work in the teens somewhat, but they don't tend to work very well in the younger kids. It's always risk-benefit with medication.
Medication is just part of the equation. It's not near all of it. I would say that it's less than half of it. Just because a person gets the brain activity and balanced somewhat doesn't mean that they can function.
The thing about psychiatric care for children, in my experience, is that the psychiatrists, even though they're knowledgeable, don't have a lot of time to talk. Psychiatrists, their job more or less ends up being to give them pills. In Damien's case, medications, the stimulant medications, make him more violent.
Disparity in care, now on Southern Remedy.
Dr. Summers, let me ask you this from the psychiatric standpoint. Some of my patients with means are angry because they think kids who are on Medicaid actually have more access to care than those who are traditional private patients. And even the ones on Medicaid say they can't get appointments.
Yeah.
So, for us to sit here and say, you ought to do this when the system is dysfunctional, do you have any further recommendation?
There is a very significant disparity in availability of services and who receive services, and a lot of those disparities are associated with social economic factors. It's associated with stigmata, it's associated with insurance, it's associated with the availability of people. Right today, if you wanted to go to a mental health center and see someone, it would be 1 to 2 months before you could see a psychiatrist. If you call someone, you may be able to get an appointment in 2 weeks to a month, but you won't see a psychiatrist for 1 to 2 months. So we do really have a manpower problem. In addition to that, a number of the and we provide a lot of service. We provide a lot of help, and we help a lot of people through community mental health centers, university medical centers, private practicing people. We help a lot of people, but when you take a state like Mississippi, which has one of the highest rates of depression in the country, then the need is great. And if you look at children who are at risk for developing mental illness, then we have a lot of those risk factors like poverty, like racism, like discrimination, like, dysfunctional families. So it's a big problem. So we need to do a whole lot more than we're doing.
My name is Dawn Mackey, and I have a 9-year-old son who has been diagnosed with ADHD and ODD, which is oppositional defiant disorder.
Dawn Mackey says she first became concerned about her son's behavior when he was in preschool. She says Mark was frustrated to the point of being disruptive.
He had trouble relating to other children in his classroom. It seemed that his communication skills were a bit above theirs, and it was really frustrating for him to try to talk to them and be on their level, and they were a bit more immature than he was, and so I think he expected too much, even for an 18-month-old. It continued on until he was in daycare in 4- and 5-year-old kindergarten. Didn't always want to do his work or what was asked of him, but at the same time, he had a hard time sorting out what the best decision to make was.
Dawn says she took Mark when he was 4 years old to his pediatrician first to get help. He was tested and diagnosed. She says they started working with a counselor and psychiatrist, but she says it wasn't a good experience.
I felt like there was just a real push for the medication without really listening to what was going on, and it was a very, very busy practice, and I just kind of felt like parents were taken in one door and pushed out the other, and that I really wasn't listened to. I was talked down to, I was disrespected. I didn't want to have a 4-year-old that was already medicated. I would say even at that time, I wanted to research what are the tools that we can use? What can we do besides instantly pushing a pill on this child?
She says she went to 2 more mental health specialists before feeling comfortable about Mark's treatment.
And again, I really was worried about having my child on medication. The child was, I guess, 6 years old maybe whenever we first started. And I remember asking him, how do you feel when you take your medicine? How does it work for you? And he says, I get less annoyed with people. People don't make me so mad.
Dawn says Mark attends a special school which focuses on students with learning challenges. She says he's making progress, and she hopes he'll grow out of the need to take medication and be able to cope with his condition.
We've actually seen that just in the short time he's been working with this therapist. And he's able to step back and take a breath and not react.
Where can a parent take their child in a mental health crisis?
What are the appropriate options for the appropriate setting?
Sad to say, right now, if you acutely need a psychiatrist, if someone is suicidal, if you have a child who's threatening to really hurt themselves, or homicidal, threatening to hurt someone else, then the emergency room is the only access that we have right now for our children. That is not okay. We need to fix that. But as Dr. Summers said, there are a lot of people working very hard, doing a very good job. They're just not enough. One other issue that we have is that there's probably not enough efficiency in our treatment. So to use evidence-based treatment, not to treat someone forever. Most children don't need forever treatment. What they need is good, adequate treatment acutely so that it doesn't blow into a humongous problem later on. So better, quicker access is what we really need to work on.
All episodes in this series on mental illness in children are available on the PBS video app or on the MPB YouTube channel.
Go to mpbonline.org for web extras and more discussion about children's mental health.
For all of us here at Southern Remedy, thanks for watching.
Southern Remedy is underwritten by a grant from the University of Mississippi Medical Center.